Well, welcome everyone to this, the last George Eliot board before Christmas. Hope you've all stayed safe in the pretty awful Greek weather we've been having over the last few days. We've got a pretty full board meeting today. We've had an interesting board development session this morning talking about the work we do in terms of improvement and our leadership on that. As well as some other topics, including the financial situation and challenges that we face, but we will come back to some of those later. We've got a pretty full board agenda, so with your forbearance, I'll keep things going along at a reasonable pace, but lovely to see so many members of the public with us today. So without further ado, any declarations of interest which you would like to make us aware of, please raise a digital hand. Okay, I can't see any digital hands raised. So we'll move on then to the minutes of the meeting held of the George Eliot board on the 3rd of October. Any points of accuracy which colleagues would like to highlight? Julie kindly chaired that meeting for me. Can't see any digital hands raised, so I'll take them as accurate, and therefore we move to page 14 of our pack, I think, for the matters arising from that meeting. And the first was for Lorraine to bring back a report with Natalie to the board today on maternity governance processes. That's on the agenda, so we'll come back to that later. Thank you, Lorraine and Natalie. And then Robin or Natalie to contact their counterpart at Worcester to gain ideas for taking work on menu co-production forward. And we'll be coming back, Natalie, with a verbal update, or from Robin now. So, Robin?
Yeah, thank you, Chair. I've spoken to Helen Lancaster, the Chief Operating Officer at Worcester Acute. She's linked us in with the relevant people in their catering teams, because their catering teams are outsourced. So we're currently in discussion about menu options, and we'll bring a full update back to next board.
Okay, great. Thank you, Robin. Any matters arising that you think I've missed from that October board meeting minutes? Okay, we'll move on then to the November and it was the full board foundation group meeting. Lovely to have Worcestershire Acute fully joining us for the full time. Those minutes of the meeting held on the 1st of November, if there are any points of accuracy, could you please raise a digital hand? Okay, can't see digital hand raised, so I'll take those as accurate for those purposes. And then we had a couple of action points which are in process. The first was for Catherine and colleagues to ensure analysis takes place to compare cancer diagnoses from the ED attendance across each trust. That's ongoing, Catherine, is that correct?
Yeah, I think we need to perhaps ask the help of the cancer boards to help us to track that and monitor that, Russell. It might be a little bit difficult to get that emergency in the IT information support, but I think the cancer boards could help advise us on that.
Okay, so what do we need to do, Catherine, to get the cancer boards to help us on that?
Oh, if I pick that up, and then if we leave this on the actions, then we could come back to it so that we don't lose track of it. But I think we just need a bit more information about how we measure that. Okay,
super. Thank you. Thank you, Catherine. And then Robin and colleagues to look into recording theatre utilisation data by cost per minute rather than by a percentage. That's in hand, Robin?
Yeah, that's in hand. Hack gave a brief update at the last board, and Hack and I'll continue to work through that.
Okay, thank you. And then finally, the gender pay gap annual report to include a detailed breakdown as to the female to male rates. That's ongoing, so I think, yeah. I think it would be just a general point. I know it's a requirement to do a gender pay review, but I'd be interested in other sort of...
Calling Dr. Ahmed mobile.
Calling Dr. Ahmed.
Apologies.
Okay, I found this on the web for trusted and other sort of Dr. Ahmed. Check it out.
By the way, if you have another request.
I apologise, that's Siri getting very excited and not even sure who Dr. Ahmed is. But coming back to the point I was trying to make before I was so rudely interrupted by technology, I would like to look at other inequalities that exist in our pay arrangements. So, for example, particularly on the EDI side and the LGBTQ side, if there's any data there which would inform the board of any unintended disparities that the board need to be aware of. Sarah?
Yeah, so we're actually bringing something to the 4 boards in February, because as part of the EDI improvement plan, one of the high impact actions is to have pay gap reports based on different protected characteristics. So we have a plan for those moving forward.
Super, thank you. Okie dokie. Any other matters arising the colleagues would like to comment on? So at a canter, we move into the Chief Executive's report. An awful lot going on, Glenn. Please try and provide an overview. Thank you.
Thank you, Chairman. I won't go through the entire report. It starts with quite a big section on NHS finances, and the context of that is an ongoing discussion between the National Chief Finance Officer and the Treasury around a number of financial pressures, just a core activity-based pressure, but then also the impact of industrial action and the impact of inflation, which he was asking for around 2 billion. Unfortunately, the Treasury did not provide additional funding on top of the 200 million that we announced in the summer, some of which was being held back nationally. And so as a result of that negotiation, some of the national funding has now been released into integrated care systems and into trusts, but then there have had to be some serious conversations about what we do in response to that, including the opportunity, if we wanted to take it, if that's the word, to slow down on elective recovery. Now, we've obviously considered our own position as an organisation. We discussed that quite a bit in workshop, and we've had to submit a separate return, which Hack will come back to later in this report. It was our considered opinion that we did not want to hold back on elective recovery, that we wanted to continue at the pace that we've been progressing that, which is a good pace, for the benefit of those patients, but also the potentially could be an impact on urgent care. So we've had to look at the financial plan for the organisation, looking at the additional funding that did come through this full settlement, and reassessed our plan. And we've arrived at a situation where the plan is a little bit tougher than it was at the start of the year, but we're sticking to it. And we'll come back to that later. But it has highlighted across the NHS some concerns around the increase in the headcount of the NHS compared to pre-COVID levels, and whether we've delivered the associated productivity as a system. Now, I think when you look at our position on that, I think we can point quite positively towards increased activity, particularly in elective care, better management of urgent care, including some of the changes that have gone through RED, improvements in areas like maternity from a quality perspective. So there's a combination of quality and activity related benefits that we can point to. And I'll get the opportunity to do that later on this week, where we meet with the national team to discuss the system financial position, including ours. I also don't think it's a really important thing for us to focus on as we look into next year's objectives. I've never been shy to focus on improving the financial position of the organisation as a means to delivering more activity or better quality. So the two do link positively. So we will continue our focus on that, and we'll continue, hopefully, to show the improvements that we've tracked as an organisation over the last couple of years. So won't go into that one anymore. Volunteering is then referred to. We had a really good talk at our full boards workshop from Thomas Hughes Hallett. I know across the group, individual leads, particularly chief nursing officers, have been linking into him to take that forward. I think probably when you look at the group position, George Eliot was the strongest in terms of its existing work with volunteering, but there's always more of an opportunity to do more. So we will take that forward. And then talk about leadership development. There's work being led by the Association of Groups, but we're also looking at a group-wide program of teach-ins where we've got some people with lots of experience across the group, and to bring our cohort of middle managers together to learn together will be a good opportunity there. So that's being pulled together. I then refer to the replacement electronic patient record program, which disappointingly is not moving at the pace that we wanted it to. UHCW took the difficult decision to defer their implementation that was planned for last month, and that has consequences for our timeline, consequences which we're not entirely sure of yet. So we are working that through. We have not signed our contract with Cerner. We therefore potentially have other options should that timeline not meet our needs. So we will update the board as that progresses. And then a series of updates on, firstly, the Directorate of Medicine. And what I love about this update is there's a huge focus on non-admitted activity here and pathways that are not about bringing people into the hospital. So it's really good to see virtual ward, same-day emergency care, for example. Then an update on our Green Champions, which is good to see all the work that's going on alongside that big move. And then at the end of the report, a large number of visits to departments from execs and non-execs, which is good to see how connected we are to a workforce who, I'm pleased to say, filled in 52% of our staff surveys this year, which is a real step up in terms of our staff survey take up. So we look forward to the results of that landing quite soon. Happy to take any questions.
No, that's great, Glenn. And just before you do, I think it's worth, from a systems perspective, congratulating one of our colleagues in the system, Dr. Kiran Patel, who's been the Chief Medical Officer, UHCW, who's just been given the same position over at University Hospitals Birmingham. So we wish Kieran well in that future role. Any questions or perspectives to Glenn? What's worrying you most at the moment, Glenn, as we head into winter? Well, winter's definitely here. And I'm sure Robin will touch on this when he talks about performance later. The number of ambulance delays across the NHS this week has been significant. The amount of demand is significant, and we continue to see record numbers of A&E attendances. And alongside all of that, we do want to continue our trajectory of improving elective care. So it's just that normal kind of feeling as we enter the winter that it's going to be, I always say this, it's going to be the toughest winter we've had, and it feels like it might be. So that's the worry. And I suppose the human side of that is the impact on our workforce of the continuing demands that are placed upon them. And so it's really important that we support them. Yeah, no, absolutely. And you did mention volunteering in your report. I'd just like to have a big shout out to Becky Millward, who leads our volunteering sort of coordination at George Eliot. Becky, thank you very much for everything you do. Okay, we'll move on then. And occasionally we have to, as a board, use emergency powers for urgent decisions. And one of those more recently has been the financial forecast, which Glenn mentioned, and our plan resubmission. We did discuss this in granular detail this morning as a board, but Hack, what would you like to just provide as an overview for retrospective approval?
Yeah, I'll just draw out some key elements. Thank you, Russell. So the paper is requesting formal approval of the plan resubmission that all ICBs were asked to submit by the 22nd of November, hence the need to use the emergency powers to reach that decision. The plan resubmission was on the back of some additional funding being made available to ICBs for industrial action. But as Glenn said, that was through some existing national NHS resources. Glenn's covered the background, so I wasn't going to go into that. But moving on to what we actually submitted, we submitted a break-even financial plan, and the performance and capacity metrics that we also submitted are set out in the paper. Notably, we're still planning, as Glenn said, delivering the key performance targets around waiting times, cancer and A&E performance. And also Glenn also I think touched on our approach to this, which is around focusing on improving quality, operational performance and money all at the same time. And it's building on our approach that we've taken over the last few years. So it's not a divergence from that approach. Just wanted to flag some of the key assumptions and risks, just pull out a couple of areas, some income risk around the CDC income clawback and some risk around some income from South Staffordshire for emergency activity. We've got support from our ICB, but we haven't reached agreement on those issues yet. And there are some ambitious but realistic assumptions around further productivity improvements, which to some extent are reliant on being able to ring fence our elective orthopaedic beds. And as Glenn has just said, we are under a lot of pressure. There is some risk, so there is some risk around being able to continue to do that over the next few months. But despite the financial challenge, we have included further investment in international nurse recruitment. So this is about also looking to the future as well. I'm reasonably confident we will achieve the financial break-even based on the mitigation set out in the paper, and we've agreed those with the directorates and with the executive team, and we have some flexibility within our position to deal with the risks that I've outlined. But I'm kind of more mindful of getting to the best exit run rate and making sure we get into the best possible position going forwards into next year, because we know that will be a significant challenge next year as well. So, and finally, since writing the paper, we've been informed of some capital funding incentives for next year in relation to achieving financial break-even this year and also delivering some performance metrics related to A&E for our performance and ambulance handover times. So we're mindful of those as well. So again, capital resources are challenged. So if we could deliver those targets, that would certainly help the capital plan for next year as well. So the recommendation is for formal approval of the resubmitted plan that was originally approved using emergency powers.
Very clear, thank you, Hack. For members of the public, we did discuss this substantially this morning. Any questions, further questions to Hack? I can't see a digital hand raised, so if you're not happy to approve, please raise a digital hand. Thank you, Hack, and I'd like to thank all of the sort of senior leadership team who very quickly had to recast their numbers given the deadlines that Hack has outlined. So thank you very much for all your efforts. We'll therefore move on to the mid-year review of Trust and Foundation Group objectives for this year. Glenn, are you going to introduce or just hand to Jenny?
Yeah, and Jenny's done all the work on this, so I'm very happy for Jenny to lead us through the update.
So I'll just be very brief then. This is our 6-month review of our progress. You can see that as we progress in all areas across the annual objectives. Obviously, we do have some areas that have been impacted by the pressures that we've seen sustained throughout the period. However, there is actions in place to progress those items that are still amber or still yet to be delivered. The report just pulls out a few of the kind of key achievements, which I think you'll agree are aligned very well with our key areas of focus and priority around things like recruitment, staff wellbeing, etc. Obviously, we've got still Q4 to deliver the remaining of the actions. I'll leave it there, but happy to take any questions.
Thank you. Any questions or perspectives to Jenny? Glenn?
Yeah, just to add, I think it is really good to see the progress that's been made over the first half of the year, particularly bearing in mind the pressures that we've had as a organisation and as an NHS. So there are a good set of objectives that are really progressing well.
Thank you.
Thank you, Glenn. Any other comments from colleagues? Let's try and get everything to green by the end of the year. That would be great. Thank you, team. So we'll move on then to the Warwickshire North Place Delivery Group Progress Report. I'm back with you, Jenny, and welcome, Sarah.
Yeah, thank you very much. So our place report highlights the activity that has been undertaken throughout this reporting period. As you'll note from previous reports, we've started to have a focus on a particular theme, and this time the focus was around mental health, which was a really great discussion in our delivery group and really connected partners around the issues and some of the kind kind of key areas where we needed to make connections. So that was really positive to see. And also the discussion in the subsequent place executive highlighted some particular areas of inequity that we have subsequently picked up with discussions with ICB colleagues. So a really productive conversation. The rest of the report highlights the progress against the programmed activity, and you'll see that we continue to make significant progress. There is one item read on the report which we are progressing with colleagues and is due to discussions with colleagues around the pharmacy programme. In terms of the highlights, there is an appendices which just highlights a number of specific things that have progressed this period. I just want to pick out two things on this, if I could. The one is just to celebrate the Frailty Hub, which has been done in collaboration with our primary care colleagues with Out of Hospital Services and George Eliot, that was launched, which I think is a great example of partnership working. And the other one I want to just pick up is that we have now reinstated our estates forum, and we did have specific conversations relating to some of the specific challenges in primary care estates as part of that discussion. Happy to take any questions.
Thank you, Jenny. Any questions or perspectives? Julie?
Thanks, Jenny. A really good report, again, just shows what can be achieved at the level of place. My question is around 24-25 planning and how this will be used in terms of 24-25 planning, and whether there is any further discussion about delegation of resources at place level.
Thank you. So the discussions with regard to delegation is happening through the care collaboratives. There is actually a discussion on the next place executive around the arrangements and the progress against that. So hopefully we'll be able to report more on that going forward in the next report. And we are fully engaged in the matrix teams that are supporting those developments, where we've put our staff in to work alongside ICB colleagues around some of those proposals. So that's in progress. In terms of the planning question, we have actually agreed a date for a planning workshop, which we're going to take forward with our delivery colleagues in the Health and Wellbeing Board as well, and that's programmed in for the new year. We intend to refresh rather than significantly revise the existing place plan, because we think those priorities remain the priorities that we need to focus on, subject to that discussion, obviously.
Thanks, Jenny.
And Catherine?
I was just to support Jenny on the conversation around mental health. I think you can see by looking at the data there are some significant challenges, I think, particularly around the dementia diagnosis rate for North Warwickshire, which is considerably lower than the national average. And I think by exposing some of these differences, it helps us to look for where there are opportunities to improve care for our local population and provide support for those who need it. So it's really a tangible example for me of place working in a way that can drive improvements for the local population.
Yeah, no, absolutely, Catherine. And Sarah Restrick has made a similar points in on other topics in the chat box. And Paul Capener?
Thanks, Chair. Good to see the discipline of risk and risk management within the appendix. Just one observation. There are no due dates for the actions that are listed there, the mitigations, and I think it'd be helpful to understand that. Some of these items have been outstanding possibly back as far as February, so just an observation on that. That would be helpful to see.
Yeah, can we do that going forward, Jenny?
Yeah, I'm happy to pick that up, thank you.
And can't see any more hands raised. Just one for me on this community pharmacist issue, Jenny. Is this particularly with reference to palliative care drug provision?
No, it's more to do with advice and guidance within pharmacy settings as opposed to anything else, and to do with the opportunities around that preventative piece. And we are picking it up through our clinical professional partnership, and we are linking in with primary care and also with the ICB, but it's not to do with that now.
Okay. just outside of this meeting, I'd like to understand in Warwickshire North how palliative care drug availability occurs out of hours in a community setting and whether there are any issues on that. I know it's an issue in South Warwickshire, but I'd just like to have a briefing if someone can arrange it for me regarding Warwickshire North. Okay, colleagues, thank you, Jenny. Thank you, Selma. We'll move on then to the Estates Q2 report update. Robin and Kirsty, over to you.
Thank you. I'm just going to take it that the paper's read and just pull out the important bits, if that's okay. So on a positive note, we've got some dates now for our Community Diagnostic Centre Phase 2 going live. So although the building on the ground floor will be ready at the end of January, it takes a little while to install the CTs and MRs, do their configuration and commission them. So they're going to be ready towards the end of March for use. The first floor, though, will be ready in advance of that, and it hands over to us on the 23rd of February. So hopefully within a few days of that, we'll be up and operational. Unfortunately, our 30 bedded wards, it's not quite so good news there with them being delayed. The scheduled date at the moment is the 4th of April, but the sticking point is the provision of the lift to those 2 new wards. They're being chased every week to see if there's any improvement on that date, but unfortunately, as yet, they aren't. We have explored the possibility of installing a temporary lift, but unfortunately, they're not suitable either or available. There seems to be a bit of a global issue with lift provision, and particularly in Europe. Our maternity theatre 2 has been completed. It's looking very good. We've just had the second lot of validation reports in, and we'll hopefully be sharing that with Natalie and with the IPC team so that we can bring that theatre into use. And then we can start on Theatre 1, and then that's it on Labour Suite and Skiroo. It will all be complete. We've had to suspend the works on Drayton Ward just because we've had supply issues with the bedhead trunking, but we've got it all here now on site, and we'll be starting that in earnest in the new year. We fully anticipate that that work now will be uninterrupted until the end of March, so that will be Drayton Ward with a full refurbishment, which will be fabulous as well. And mortuary extension, although we're still waiting on a decision from the ICB about the longer term arrangements, we are still proceeding with our mortuary extension scheme in readiness to start in the spring, which is the best time for us to do that. So detailed design is being undertaken, and we're looking to go in for planning next month. So hopefully we'll be in a position to start that work, but it is pending an outcome from the ICB at the moment. And the 4th floor maternity, the anchor radio area has now all been stripped out. It's been stripped back to the mortar, basically. It's a fantastic area, and it has enabled the estates team to actually look at the building infrastructure in more detail, and particularly drainage and infrastructure particularly, which is very interesting for such an old building. Our site reconfiguration, there have been business cases that have gone to TMB, obviously on the back of the new wards being available and CDC releasing space. To get us through this winter, though, we've looked at some areas to support additional beds, and the work at Arbury Lodge is due to be finished at the end of this week. And we're looking at putting some beds in an admin area in CCU, and that hopefully will be done before Christmas. And then lastly, the estate strategy. It has gone through our estates operational group. We've had lots of comments back, which is brilliant. We'll be then taking that document once those comments have been incorporated through TMB, and it will be coming to the board in March. So that's a whistle-stop tour through the paper. I'm happy to take any questions.
Lots going on, Kirsty. Thank you very much. Questions and perspectives, Simone?
2 questions, if I may, Chair, please. The first is, Kirsty, what are the consequences for the contractor of non-delivery of the lifts? That's the first question.
Yeah, there are LADs applied in the contract, and we're working through with the contract administrator. I think it's the LADs are £500 a day, which isn't a lot, but it's something towards it. They are the ones doing the chasing. Myself and Robin have met with them, and we have stressed the importance of getting that lift here on site, but we will be managing the contractor through the contract to the letter.
Okay, thank you. And then secondly, great to see all the improvements in maternity. I just wonder if there's any update on the refurbishment of the coffee shop area?
So the coffee shop's actually finished. We're just waiting on some furniture to be delivered outside, and then we'll be starting to discuss opening it up with the League of Friends. They have struggled a little bit, I think, with recruiting volunteers, but I know they were talking to our comms department about getting some more interest for that area. But we will support the League of Friends to get it open as soon as we possibly can.
Thank you.
Thank you, Simone. Just keeping things moving quickly. Robin, did you want to come in on that?
Yeah, just to say, to reinforce that we're working with the League of Friends in order to get that coffee shop open. That's our first option. Obviously, if the League of Friends are unable to do that, then we'll review our options as to how we use that facility to provide a service to the patients and families using that, and expectant mothers using that service.
Yeah, no, and we're really grateful for the work of the League of Friends. Julie?
Sorry, Chair. Yeah, it was just the point about estate strategy. How are we working with the system to align to any works on system estates?
So the estate strategy, because there's an estates strategy for the ICB as well. All of our schemes have been identified in that estate strategy, which I know HAC leads on. So they're interlinked. So all our major strategic schemes are in both. It links with the digital strategy workforce, the Warwickshire North Place strategy. It references everything in there to pull it all together, as well as our own directorate's service development plans. So we've tried to incorporate everything in that document.
Strategy upon strategy. Thank you, Kirsty. And then finally, Glenn, for that.
Yeah, I was just emphasising the point that Kirsty made about that whilst we're disappointed that the lift isn't going to be available for us to bring on board the capacity just after Christmas, and it links to the earlier point, we are creating the bed capacity across the site in order to ensure that we can still deliver on our winter plan, and it will be slightly more expensive to do it that way, but we need those beds to be operational this winter.
No, absolutely. Thank you, Glenn. Okay, thank you, Kirsty, for your hard work. Please thank your team. We'll therefore move on to the quality part of our agenda. And the first is to receive and note the report on safe nursing and midwifery and AHP staffing. Natalie?
Thank you, Chair. I'll take the report as read and highlight a few key areas. Firstly, to say we have seen a number of successes in our recruitment, and with that predominantly accumulating in a reduction in our vacancies for registered nurses. We have, as you heard earlier, supported international recruitment, which has joined our workforce, and I have just celebrated with 86 of those internationally educated nurses, a year of them coming into the George Eliot. Pharmacists are an area of focus for us currently. You'll note in the report that they have a 25% vacancy rate. That is after the successful recruitment and drive for band 6s. So we now have a focus on our band 5 pharmacists, but we're ensuring that obviously all areas are covered. With regards to safety and patient outcome measures, you'll see that there has been a reduction in the number of red flag incidents in October, and we monitor these very closely, reviewing quality and safety in anything relating to staffing and look at the escalation processes. There were 8 within maternity, but I know that Lorraine mentions that in her assurance report as well. Our key is to focus on retention. Now that we have our successful recruitment in place, it's about retention. And there are areas of focus that are highlighted in the report, particularly looking at our professional nurse advocates, our flexible working, which is part of our strategic objectives, a legacy role, and also looking at preceptorship, because what we want to do is ensure that we have the workplace and to keep our staff here. On that note, we have recently received a healthcare Support Worker Quality, Pastoral Quality Award from NHS England. This is a pilot and it's about to be nationally launched, but we did achieve. And we have just had notice that we have also achieved the pastoral care for our internationally educated nurses, and we can now proudly display that quality mark. And not to stop there, we have submitted our evidence submission for our preceptorship work. So we're really driving that side of retention. The report does detail the continued pressure within the organisation, the extra capacity, but I am glad to note also that we have slightly reduced the number of internal moves that we have had to make with our staff to ensure the safety across the organisation, but also want to recognise that we have been able to reduce our agency spend. And we had noted previously that our drive is to reduce all of our temporary spend, but particularly with agency workforce. Happy to take any questions, Chair.
Very comprehensive, and thank you for your hard work, Natalie. Any questions or perspectives for Natalie? Catherine?
I just want to say thank you to Natalie and colleagues that are working in the corporate nursing team and others to support our international nurses coming into the organisation and the healthcare support workers. We talk a lot about well-being, but it's nice to see these things being recognised externally as well.
No, well said. Thank you, Catherine. Okay, well, one of the challenges we know we have with an ageing population and increasingly obese population is acuity. So the report on acuity and dependency reviews and outcomes of associated establishment reviews. Back with you, Natalie.
Thank you. It's a very comprehensive report, but the paper outlines our biannual establishment review, and that's in accordance with the national guidance, and it incorporates the validated acuity and dependency tool, the review of nurse sensitive outcome data, and the professional judgment of the heads of nursing, the corporate nursing team. And this year we have included our finance partners to ensure that we do have that alignment across our establishments, our rosters, and looking at the safety and safe staffing areas. The areas in the paper are general areas and the emergency department. The other specialities have specific minimum safe staffing levels, and they are within the body of the report. And maternity are currently undertaking their planned external birth rate plus, so that report will come at a later date in 2024. In general, the set establishments and the safe planned shift numbers are in alignment and fundamentally match the safer nursing care tool that is used and a professional opinion. One of the main areas that has a mismatch with funding in the nursing establishment and safe staffing levels is in the emergency department, which is highlighted in the report. This has taken place with the change and reconfiguration in the emergency department that happened during the pandemic. And the alignment has been highlighted to us in our FPE meetings, and the directorate are being fully supported to ensure that the future budget aligns with the past reconfiguration and the safety requirements. There are a couple of anomalies with the safer nursing care data, which you will have noted, and they're predominantly in our children's assessment unit and our Captain Tom Moore unit. The report details why this may be, and it will be addressed by the next review. The paper highlights the next steps, some of which are with the directorates through the budget setting and in conjunction with their financial partners. Others are through the business case review and transport management board, and 2 are with the corporate nursing team to look at and review. The board can take assurance, and I take assurance in the process, and that fundamentally our staffing levels and establishment that currently in place are safe and able to provide the care that we need to do for our patients and our community.
Very clear closing statement there, Natalie. Thank you for that clarity. Questions and perspectives, Glenn?
Yeah, thank you for taking us through that. I suppose one of my concerns about the approach to acuity reviews is that they kind of automatically create a growth in establishment numbers, and I have a concern that you can't be as scientific as the tool would imply, because obviously there are other factors that play into this, particularly actually the experience of staff So comparing an established experienced member of staff to someone who we employed from an agency, for example, it just doesn't compare. So I'd be particularly nervous about chasing higher levels of staffing if we're going to fill them with agency staff, because I think that's potentially going to make matters certainly not better, if not slightly worse. So I've just urge kind of a triangulation of looking at that experience, looking at some of the quality indicators as you do, alongside what the tool tells us. Otherwise, we could make it worse by adding agency staff into an area where we're probably better off with experienced employed staff.
Absolutely. It's a false level of assurance sometimes, the amount of heads on an issue if it's agency heads. Jackie?
Thank you, Chair. A quick question for me, Natalie. Do we understand the impact that the enhanced supervision has in terms of looking at the headcount that we're looking at here? Because you note in your report that there's been an increase in the requirements for that. How does that get reflected through this exercise?
So the acuity levels through the Safer Nursing Care tool, it's quite complex, but on a patient that is scoring as a 1B is actually a patient that generally is a dependent rather than an acute patient. So that quite often will reflect on the requirement for enhanced care. So it does add into some of the Safer Nursing Care tool data, but absolutely concur with Glenn, and we need to do that triangulation, which is where the professional judgment part comes in. Do we need to add into our establishments because of the number of enhanced care, or do we need to look at getting our established staff and our junior workforce developed, skilled, and therefore we will see that reduction because of the ability to actually staff it to your planned numbers. So it's a bit complicated, Jackie. It does include it, but we do need to look at it and review it in its totality.
Okay. Jackie, if you want any further clarification, I'm sure Natalie would be happy to continue the conversation with the board. And thank you. And Julie?
It's just building on the points really, but being a bit more specific, Natalie. Thanks for the report, it's very clear. But in terms of taking this forward and not being an automatic increase in budget, the national focus is around productivity and the link to 2019-20. So in that further work, how will that be taken into account?
So part of that is, as we've already mentioned, the increase in our bed base and activity in that productivity. We've also, you'll note in the report, discussed the new wards and the Captain Tom Moore and the development of the SAU and our day procedure unit. So all of that will factor into how we're looking at the establishment reviews. The further piece of work when we're looking with the directorates is looking at productivity and how can we look at the workforce that we have in a different way and the skills that they have, looking at the development of clinical nurse specialists, advanced care practitioners who can then undertake those potentially the clinic works, some of the minor ops procedures. So always looking to improve the quality of care for the patient and to reduce our waiting times.
Thank you, Natalie. I'd just like to sort of build on slightly Glenn's point, but also a point Julie's made in the past, not for now, Natalie, but going forwards, is how we build in an assessment of a patient's experience, because a lot of this work is sort of very algorithmic almost and very mathematical. And I understand that the professional judgment filter that it goes through. But, you know, there is nothing better than to be looked after by an experienced nurse who's comforting and kind, rather than someone who's inexperienced and nervous. So just maybe with Catherine, think about how we can talk about patient experience more in all of these regards. I think would be good. Natalie, thank you. Thank you for your team's hard work. We'll move on then to the maternity assurance updates. Lorraine, welcome.
Thank you. And so I'm going to report on October's data. I'm going to take the report as read, but would just like to pick out some highlights. So October was a very busy month for births. We had 188 a month, and we certainly felt that across the system. It was very busy, but actually all our women still received one-to-one care in labour. Our birth to midwife ratio was affected obviously at 1 to 30 because of the increase in birth and sickness and maternity leave levels within our staffing. But all outcomes were good. We had no stillbirths, no neonatal deaths, no maternal deaths or no SIs in month. Our stillbirth ratio remains at 1.88 per 1,000 births, and that's way below the national average of 3.6 as per Embrace. We have 25 risks on our risk register, and they're all up to date. We had 55 DATEC incidents reported, and as of the end of the month, we had 30 overdue, which is well within our target. So that's really good. It's a busy time at the moment. We're prepping really hard to achieve CNST, and that's due for submission to the board in private boards today, but the cut-off for that is the 7th of December. Our training compliance had dipped in months slightly, but we're still on track to achieve the 80% trajectory for CNST. We also had our Saving Babies Life review. We know that version 3 was published in June 23, and there's now 6 elements. We were managed to achieve 100% in one of the elements and 59% overall, and we've just resubmitted November's, and fingers crossed that we will also achieve that in line with CNST. In October, we also had the LMNS come and review our insight visit with regards to Ockenden. We're awaiting the report on that, but the initial feedback was really positive, and they could see the improvements that had happened across maternity services. As Kirsty has outlined, our Theatre 2 is complete and looking really good, ongoing work. And obviously I can't end without saying that we're really pleased to have achieved good, well-led and safe across maternity services. And I think that's really important to note with the scrutiny that maternity services are under. That's a real achievement. So amazing team, and happy to take any questions.
No, absolutely. And I'd just like to reiterate my absolute pleasure in this external endorsement of the quality of maternity services at the George Eliot. Fantastic, well done. Questions and perspectives, Glenn?
Yeah, I was going to echo that. I mean, I think all the results are in now from those CQC inspections. I think only 1/3 of all units nationally achieved good or outstanding. So I was delighted to see all 4 maternity units in the group were good. So it's very well done to all of our teams, but and particularly challenging times for maternity services. It's great to see the quality that we offer our local patients.
No, absolutely, and the safety with which we provide maternity services to our local citizens. Any other questions or perspectives? Okay, we'll segue in then to an assurance briefing following the verdict on the trial of Lucy Letby, or the issues around that. Natalie and Lorraine, back with you.
Thank you. So the board is aware of the sad events that took place in the Countess of Chester Hospital and the subsequent correspondence from the NHS England to review systems and processes for assurance, in particular the ability of our staff and all patients and families to raise concerns and to be listened to. In October, at our Quality Assurance Committee, Lorraine presented a full report with regards to maternity and our neonatal services. We also then wanted to look further trust-wide at all of the organisation, and the report that's in front of you does that. So it covers not only maternity, but from a trust-wide point of view. A statutory inquiry is being led by Lady Justice Thirlwell. In the interim, this paper is presented to the board to give assurance of the processes, systems and review mechanisms that are in place across the George Eliot, inclusive of adult services, maternity services, paediatrics and our SCABU. The report demonstrates that the Trust uses data outcomes and qualitative mechanisms to triangulate care and responses. And I'm happy to take any questions. It's a very comprehensive look at all of the services across the organisation. And as mentioned at the beginning, I'd like to thank Lorraine and Claire Haywood for putting this together.
Thank you, Natalie. Any questions or perspectives from colleagues? Julie?
Sorry, Chair, I couldn't get off mute. I see it's a really comprehensive report and it's very thorough and it's really assuring. I suppose my one question is going to be, and I'm not sure we know this, is did the Countess of Chester have the same arrangements in place? Are we absolutely, Russell's shaking his head, or do we not know what they were missing, where their gaps were, I guess is my question.
I think that's exactly what the inquiry is going to pull out. The Countess of Chester looked at a period from 2015 to 2017, roughly. Some of the processes that you see in the report were not in existence then, but others were. The inference from the court case was that no, they didn't have all of the elements in place that they should have done, but that will come out more fully in the inquiry. And the inquiry is also looking across the nation to have an understanding of whether there's been measures learnt from past reviews and inquiries, and also at the governance processes that were there at the time.
Glenn, anything you'd like to add to that answer?
Yeah, obviously, in particular, the Freedom to Speak Up arrangements were not in place at the time of the issues at Council of Chester. Although what I would say is you can have all the systems and processes in the world. The most important thing is the culture within the organisation and encouraging a speak up culture, a listening up culture, and a following up culture. So I think all of those things are going to be important. So it'll be interesting to see what comes out of the inquiry. But as I say, the culture of the teams and the organisation is, I think, what drives these safety issues.
Glenn made both the points I was going to make. Natalie, Naj, Lorraine, Claire, thank you all very much for your hard work on pulling all that together. We'll therefore move on to the mortality and learning from deaths for Q2 report. Naj?
Thanks, Russell. I'll pick out some of the headlines. So from the mortality part of the report, start with the data that we have available. So with SHIMI, which is deaths within hospital and 30 days of discharge, we're still within the expected range. Has gone up slightly, but still, as I say, within expected range and still around, now got to pre-pandemic figures. HSMR, which is another sort of data which we look at for mortality, looks at in-hospital deaths and looks at 56 diagnosis groups, which count for 80% of in-hospital deaths. And whilst we remain an outlier in that at 108.8, that's shown an improvement, and that's a month-on-month improvement, which is quite positive. Within both SHIMI and HSMR, the report does contain various diagnostic groups where we are outliers, but again, just for assurance, in the last few months, we have been within expected range for those conditions as well. So there's been definite improvement. Weekend mortality is also now within expected range. And then as part of our own internal sort of processes, we have obviously our medical examiners who in Q2 were able to review 99.5% of all deaths. I think they just missed one, of which 75% of which they classified as good or excellent care. And so we look at that as well as other sort of internal intelligence, such as morbidity, mortality outcomes, structured judgment reviews, information coming from bereavement services, complaints, and PALS sort of other incidents, to just give us that internal assurance that things are satisfactory going along, patients are being looked after safely. And then finally, just to mention that in Q2, we reported 4 deaths in patients with learning disability or autism. And these also will always undergo a structured judgment review. So we do an in-depth analysis. The deaths are then notified to the National Leader Programme, which we participate in. And the Trust also continues to be represented at the regional leader governance groups, where, again, deaths are discussed and learning is shared, and we bring back the learning. And again, some of the learning is within this report. So that's the Q2 report. Happy to take any questions.
Very assuring for that level of triangulation. Naj, any questions or perspectives to Naj? Okay, thank you. So we'll move on then to the Trust-wide incidents report, Naj.
Thanks again. Thank you, Russell. Again, I'll just pick out the highlights. So again, the report does show an increase in number of incidents in Q2 compared to Q1. But when we analyse it against per 1,000 bed days, it's pretty static and has remained fairly static. And it's good seeing high numbers of incidents reported because 99.8% of them are no or low harm. And that shows we have a culture of reporting, that people don't overlook low incidents and no harm incidents. They are vigilant in the reporting, and that I think is really encouraging around the culture that we have here. When you look at the themes, again, they're very similar to previous reports. Pressure ulcers being the highest, followed by administrative processes, medications, treatment procedures, etc. The other thing that we keep a close monitor on is overdue incidents, and for that particular period, there were 328 overdue incidents, which has gone up from 299 in Q1. 70% of them are standard investigations, which means they should have been reviewed and closed within 28 days. That's the standard we've set. The other remaining 30%, they are subject to a longer timescale due to the issue that's being investigated. So these, as you would expect, medicine being the biggest directorate, has the highest number, 119. But each directorate has a trajectory, and they are working to those trajectory with their teams. And this is reported, and we monitor it through FPE and support the directorates. We're trying to, sort of follow their trajectories. We continue to report on STICE whilst we're going through this transition phase of moving from the serious incident framework to PSERF. So in Q2, there were 4 serious incidents reported on STICE, and all dealt with within the 60-day time frame. So they're all being signed off and reports sent to the ICB. And finally, the report this month also includes learning from incidents and legal cases. So another area that we can learn from what may have gone wrong or what has gone wrong and share that learning across directorates. So some of the themes are included in the report, and you'll see the 3 main sort of headings of communication, training and clinical practice. So that's our Q2 report. Again, happy to take any questions.
Again, assuring. Thank you, Naj. Any questions or perspectives to Naj? Okay, thank you, Naj. Well, well-being and our staff are incredibly important in terms of ensuring that not only do we take our corporate responsibilities seriously, but that George Eliot is a great place to work. Sarah, would you care to give us the biannual update, please?
Yes, certainly. Thank you, Chair. So this is twice yearly update to board on staff health and wellbeing. The report provides an update on the 5 core priorities underpinned by the 4 E's, and I will take the report as read. The health and wellbeing team have had a focus on staff engagement, and every area now has a health and wellbeing notice board, and a clear winter wellbeing plan has been developed to ensure that all staff are supported through the winter period. So this includes promotion of breaks, ensuring that staff have access to food and drinks, continuation of the £1 daily meal, which has proved very successful, and also offering a safe space for staff to talk when they need to. The health and wellbeing team are working with comms to ensure that all staff are aware of all the offers that are available. And I would in particular like to say a big thank you to all of our volunteers for all the support that they are offering to help out our staff. We are very grateful to them for that. Happy to take any questions.
Well said, Sarah. Any questions on the health and wellbeing report? Important to see the results of the staff survey in terms of the impact of all of this hard work that's been going on. I hope over the last sort of 45 minutes or so, members of the public have had some appreciation of the broad canvas of activities that are going on across the trust. But we'll move on now to the performance side of the board meeting and get into the detail of how we're doing in terms of the delivery for our citizens in this very difficult, challenging time. So, Catherine, would you care to start us off, please?
I will do, Russell. Well, we've talked a lot about how busy we are, so let's put some numbers to that. The data in this report comes from October, and we saw a 7.2% increase in ED attendances compared to the previous month, and the highest number of ED attendances in October since December 2022. As has been reported in the nursing paper, we were on the highest level of internal escalation, our internal level 4, for 30 out of 31 days in October. And we're on an external level 4 when we're really needing sort of support with the wider system for 12 out of 31 days in October. We had additional patients in a ward area, at least one ward area, for 30 out of 31 days in order to try and maintain flow through the emergency department and reduce the risk of overcrowding in the emergency department. And that's hard on our patients and hard on our staff. We anticipate that the pressure will worsen in the coming months, as traditionally peak bed occupancy usually occurs in the first week or first couple of weeks in January. The board will know that we've invested in 60 beds in 2 new wards, but as Kirsty's already brought to our attention, there's a delay to opening the wards because of a delay in the supply and installation of the lifts. To mitigate this, we are already supporting 28 surge beds that we have had open all year. And in October, we opened an additional 13 beds by relocating our same-day emergency service, which meant for about a 2-week period, that same-day emergency service was not functioning as normal. Also in October, the Integrated Care Board changed the pathway for patients waiting a decision to admit pathway, and this has been re-provided in the community. Rather than on site in Arbury Lodge. Those 16 beds have been planned to close, but because of the number of patients in the organisation, those beds have been kept open as well. So during the period of October, our open beds increased from 325 beds to 356 beds. And as I said, with the period when we didn't have our same-day emergency care operating, put a significant pressure on the emergency department, resulting in high numbers of patients in the emergency department most afternoons and evenings during that period. Despite all of those pressures, the 4-hour performance was 71.7%, which was comparable to the preceding 2 months. We did see an increase in ambulances waiting over the hour to offload, which was linked to the loss of SDEC, and 10% of patients spent more than 12 hours in the emergency department. 31 patients waited over 12 hours to be admitted to a bed in the hospital from the point of the decision that they required admission, and that's the highest figure in the past 12 months. This can mean that patients are not always cared for in the facilities we would wish or in the time that we would wish, and for that I would like to apologise to those patients who were affected by that. Looking ahead, this pressure has continued into November and already the start of this month, and we have plans to open a further 13 beds before Christmas, taking up to 369 beds. Had we opened the 2 wards as planned, that would have been 365 beds. So as Glenn's highlighted earlier, we've met our commitment to the number of beds that we open, but what we've lost is any additional capacity to open surge beds on top of that, which, although not funded, would have given us that little bit of additional headroom. Despite all of these challenges, there's been some really impressive performance in October, which I'd now like to move on to. As you're aware, the board is aware, we've been working really hard with our teams to improve productivity and efficiency levels and deliver more first outpatient appointments, operations and procedures than in 2019-20. October was the best month this year for planned care performance, with double the number of elective operations compared to 19-20, 25% more day cases and 5% more first outpatient appointments. Our teams planned for and delivered operations for 40 patients needing hip and knee replacements in 1 week, when historically that number would have been about 12 operations in a week. Patients receiving a diagnostic test within 6 weeks of referral also improved to 91.3%. And the area where we're not meeting that target for diagnostics relate to capacity in the workforce due to vacancies in echocardiography and urology. Recruitment is underway in both areas, and short-term insourcing in both those areas has been supported on the grounds of patient safety to ensure that our local population get their diagnostic tests, often required for cancer diagnosis, particularly in urology, in a timely manner. And turning to cancer, the faster diagnostic standard for cancer slipped back to 60% against a 75% target. And that was due to a combination of factors, including industrial action and a shortage of staff, particularly in urology, as I've already mentioned. As a board, as Hack has already said, we have committed to achieving the 75-day standard by March and are taking the steps to deliver this through addressing the workforce capacity. Now, I had written before lunchtime that it was encouraging that the BMA and the government had agreed a deal that could be put to consultants which might mitigate further industrial action. However, over lunchtime, we have heard the news that the junior doctors have announced further industrial action in the week before Christmas and for the entire week after New Year, the busiest period, as I've already said, for the NHS. And our teams have already commenced planning for that. In terms of quality, Naj has already drawn your attention to the fact that our shimmy remains within the expected level for mortality, and our HSMR is falling and has been falling over a number of months, which is very positive. We continue to keep a close eye on infection rates because we've got some really tight national targets on that, and in some areas we're either at that threshold or now exceeding it. And the infection control team work closely with colleagues to make sure we are implementing the best practice standards. Despite all of the emergency pressures I've talked about, and Russell, you were keen to hear about this, our friends and families tests positive satisfaction score for our inpatients improved for the second month in a row, with 87.5% rating the service as good or very good. And then there's some really pleasing performance indicators in workforce. The NHS staff survey response rate, which closed in November, was 52%, best in the group. And the average for our sector was 46% response rate. So that's really a massive improvement on last year, where 33% of our staff told us what they think. So this year, 500 more people have told us what their experience is like working at George Eliot. And our commitment is that when those results are available later this month, we will listen to what people have said to us and continue to try and improve the experience of people working for us at George Eliot. In terms of appraisal rates, we've seen an improvement in months to 82%. Now, that's not at the standard of 85%, but a number of directorates are now exceeding that standard. We've got more work to do with estates and facilities and with some of our corporate teams, but I think that is finally moving in the right direction, and we'll continue to push on that. One of our highest risks in the trust has been our number of vacancies, and that is still a risk to us. But a year ago, our vacancy rate was 14%. It's now 7.1%. And as Natalie has already told you, a huge amount of work has been done on nursing recruitment. And whilst there's still a way to go, it is really pleasing to see this now showing in our vacancy figures, in our agency reduction spend. So that is some further good news. Financially, in October, we're reporting a deficit of £4.2 million, which is off plan by £3.2 million year to date. This is due to industrial action, inflationary pressures, and an underachievement of our cost and productivity plan. And Hack has already outlined the detail around our route to a break-even plan by the end of the financial year. We're now in the winter, and in the coming months will continue to be challenging for our staff and for patients during the busiest period of the year. We've got to continue to focus on well-being of our staff, and it's great to see the last paper with the amount of work that's being put into that. And I'd particularly like to thank those in frontline positions, such as the emergency department, our wards and our site team, who work so hard on a daily basis to keep our patients safe. I'd like to end by looking ahead to spring. We as a board have made investments in 2 new wards, recruitment of nursing and medical staff, and in the Community Diagnostic Centre, which will help increase our capacity for diagnostics and support our cancer pathways. I wish all of these were available to us right now, but I remain confident that as a board, we have and continue to make the right long-term decisions to allow us to excel at patient care and deliver the experience our population deserve. I'm happy to take any questions, Russell.
Very well said, Catherine. Thank you for that comprehensive report. Questions and perspectives to Catherine? Glenn?
You asked me earlier, Chairman, what I was concerned about. At that point, I hadn't seen the notification of the additional strikes from the BMA. I can't emphasise enough the patient safety risks of those strikes and the impact it would have on the performance and our finances that we discussed earlier. I really do hope that something happens between now and then to stop them.
Yeah, no, absolutely. Well said, Glenn. And Paul?
I was going to pretty much make the same point, Chair. I guess the most sort of obvious point to me is if we've committed to certain trajectories around performance, which may well not be sustainable through that period. If industrial action takes place, it would have been challenging enough, but I kind of feel like that might kick the wheels off, not just our organisation, but the vast majority, if not all, across the country.
Yeah, no, it definitely will kick the wheels off. Pack, is there anything you'd like to add?
Yeah, just on that point in particular, we were asked to assume no impact or no industrial action between now and the end of the financial year. So the plans are based on that national assumption. So, but you're right, Paul, it will have an impact, but just to flag that the national assumption was no further industrial action.
Yeah, and Robin?
Yeah, just to provide assurance in the same way we've approached all previous industrial action periods. I've already met with the teams today since the announcement, literally minutes before this meeting, to start the ball rolling with the operational clinical teams in planning for those periods of industrial action, and without doubt they will have an impact on our performance and delivery. But I would like to also emphasise the fact that we talked earlier on at our board workshop about an improvement mentality and improvement culture, and the improvements that Catherine's articulated, despite the emergency pressures, the improvements we've continued to make with the elective performance, particularly throughout time, has been based on a can-do attitude by our staff and a continual drive to improve what we do and to improve the services that are delivered to the local population.
No, thank you, Robin, and thank you for your team and everyone who works when others are striking. I'd like to have a shout out to them. You're helping protect the safety of citizens in Warwickshire North. Thank you very much for standing in when others are on strike. It is a disaster for the NHS, this ongoing strike situation. Any other questions to Catherine? Well done, Catherine. Well done, team. Fingers crossed for the next few weeks. Keep up the good work. Moving on then, the summary of ratified policies. Anything you'd like to pull out on this, Catherine?
No, the paper can be taken as read. I think we approved 6 policies over the past few months, but the details of those are attached in the paper.
Okay, thank you. I'm still trying to work on the anonymisation and pseudonymisation policy. Just saying it is a mouthful. Any questions or perspectives on the ratified policies? If you're not happy to approve, please raise a digital hand. Duly approved, thank you. Then we've got the annual schedule of board business and calendar of meetings for the next, effectively, 18 months. Sarah, anything? Sorry, I've got so excited. I've moved over the patient safety incident response framework policy and plan. Naj and Claire, over to you.
Yeah, thanks, Russell. So I'll just do it. It's also here for approval. So this is the report which gives an overview of our trust position, with PSERF Transition Patient Safety Incident Response Framework, which is the change from the old Serious Incident Framework. So the report contains a policy and plan which has been through Operational Quality Safety Group and Quality Assurance Committee. So we're here for asking for approval. But I do want to just give my personal thanks to Claire and the team. They've done an amazing amount of work over the last year to get us in the position where we are. We've achieved our go live date, which was 30th of November, a few days ago. And not only the amazing amount of internal work, but also at the same time working collaboratively with in the system with SWIFT, UHCW, CWPT, and the ICB. So, my thanks, and I'm sure on behalf of the board, thanks to Claire and the team. Happy to take any questions, and if they are tricky, I've got Claire here to answer them.
No, well done, well said, Naj, and thank you, Claire and team. Any questions or perspectives on this? It is probably just worth saying for members of the public that the PSERF approach is in many respects quite fundamentally different from the previous approach. It's far more about what can we learn to ensure things don't happen again. It's arguably a more mature, more sensible focus, and really works on the sort of civility saves lives value set as well. Any questions or perspectives on this? If you're not happy to approve, could you please raise a digital hand? Okay, duly approved. Thank you, Claire and team. We do now then move on to the next 18 months of our lives in the calendar of meetings. Sarah, anything you'd like to pull out here?
Just that this is the business the board should expect to see between 24-25. I just want to note 2 amendments on the public schedule of business. Under the governance section, the board self-certifications for the G6 licence condition and the corporate governance statements, they're no longer required, but we will be doing a report to audit committee, so I'll remove those off the board schedule. But other than that, happy to take it as read and suggest approval, please. Thank you.
Thank you very much, Sarah. Any questions on the calendar of meetings? Loving the various different colours we're now using. If you're not happy to approve, could you please raise a digital hand? Duly approved, thank you. And so we're then on to the protecting and expanding the elective capacity assurance. This again is retrospective. Robin?
Yeah, thank you, Chair. This report comes retrospectively for approval. It was a request from NHSE at the beginning of October that all acute trusts submit an action plan that gave details of the actions we were taking in order to meet our 0 patients over 65 weeks by the end of March. And so because of the timescales that were afforded to us by NHSE, it wasn't possible to get this into our October board meeting, and the last November board was a foundation group board, hence why it's come here retrospectively. In essence, I'll take the paper as read. The detail, some of which we've already mentioned, is part of the performance update. It outlines the actions being taken in order for us to remain on trajectory for 0 patients over 65 weeks as at the end of March, which I'm pleased to say we are online with that trajectory. And also we have a monthly update with NHS England, a review of this plan, which actually took place at lunchtime today, the latest meeting, and NHS England remain assured that we're on plan and on track with the actions as described in the paper, and happy to take any questions.
No, thank you very much, Robin. Any questions or perspectives on this? It's a bit out of date now, but by necessity, as Robin's indicated. If you're not happy to retrospectively approve, please raise a digital hand. Thank you for your help and forbearance, and apologies, board, that so many of these things are happening so quickly that the team are having to use these special powers. We'll therefore move on to the subcommittee chairs updates and just pull out the key points. The first is the Quality Assurance Committee of the 26th of September, the 24th of October and the 28th of November, which will be a verbal update. So Astrid, over to you.
Thank you. So you can see the papers as attached there with highlights, but as you'll note from the papers today, many of the items that we've discussed today have already been to the Quality Assurance Committee, where we do give them more a little time, and you can be assured that we do have some robust discussions there. I'd also just like to say thank you to Claire. Claire Hayward. You'll notice that on previous reports we've been saying that we're looking for a slightly different way that we look to move forwards to record our levels of assurance, and we've now developed a framework which we will be adopting, rolling out and adopting in the Quality Assurance Committee over the coming meetings. That's been no small feat to get something that is fit for purpose. So thank you very much to the team for producing that.
Okay, thank you. So any questions or perspectives to Sarah? Thank you, Sarah, and everyone involved. And then we've got the the Audit Committee minutes from September and then the 21st of November. Simone, anything you'd like to pull out here?
Just three things. Thank you, Chair. The first is just to draw the board's attention to the work that's going on around the data quality kite mark. Self-evident from this meeting, just how reliant we are on data. So knowing that the data itself can be relied upon is really important. So just a very important piece of work going on across the group. And I just wanted to say thank you to the teams who are involved in that. The second is just to bring assurance to the board that we continue to look at the RTT issue. That's not quite concluded, so just to give the board assurance that we are on that. And then the third thing is, after a very good report on recruitment, that has highlighted that the occupational health contract that we have with UHCW continues to underperform. And again, just to bring assurance to the board that we are continuing to look at that too. Thank you, Chair.
Thank you, Simone. Any questions or perspectives to Simone? And then apologies, certainly in my copy of the pack, I haven't got the Foundation Group Strategy Committee notes from the 17th of October. But Julie, is there anything you wanted to pull out on that?
No, there's nothing I needed to pull out. Thank you.
Great. Any questions or perspectives to Julie on that meeting? Okay, team. So I think then we're on to any other business and then public questions. So any other business, please raise a digital hand. Okay, so we'll move on to public questions. I think we've got a couple. Sarah, are you able to read them out for me?
Yes, thank you. So Councillor Condacor has submitted 2 points. He's disappointed by the lack of progress on renewable energy and sees no sign of solar panels or aiming for excellent BREEAM standards for the new module buildings to be added soon. Why is this, and is provision being made to add solar panels at a later date? Also, he's very angry that...
Can we just do one at a time, Sarah? Yeah. So Keith Condacor, I know, has been absolutely reminding us of the opportunity here. Robin?
I think it might be me that's picking
Jenny
this
was going
up.
to come in on that one.
Okay, sorry.
No problem. So just to confirm, with regard to solar panels, we have included the solar intentions around solar panels across the site as part of our decarbonisation proposals and bids, which was submitted. We were waiting for confirmation of the position on that, but it is firmly part of those plans. So that's the response in respect to that one. In respect to BREEAM, we do follow the BREEAM standards where we can. We don't always read BREEAM excellent on everything that that we have going forward, but we do follow those where we can, and it's where it's feasible to do so.
Okay, thank you, Jenny. I'll come back to you, Keith, after I've heard the replies. And Sarah, the second question.
Yes, the Councillor Condacor is angry with the item on Warwickshire North Place. It ignores the extreme problems getting cycling provision in Nuneaton and Bedworth. Every single cycling project has been opposed by a small group of powerful councils, resulting in fully funded and partly funded projects being scrapped, such as Nuneaton Town Centre to the A5 via the Longshoot projects. Without the help of health service, we're going to have zero new cycling provision and an increasingly unhealthy population. Reports like the one of Warwickshire North Place need changing to reflect the backward steps over the last year. Will the hospital help save the projects? I think Jenny's also going to answer this one. Thank you.
Jenny, you go first.
Yeah, so unfortunately, I can't give an update on those specific projects and initiatives. What was reflected in the report was specifically projects that Warwickshire North Place is involved in. We do note the point that Councillor Condicore is making, and we will be looking to see whether we can bring forward some discussions in the Health and Wellbeing Partnership that relate to this point particularly. We are involved in a number of forums where green initiatives are talked about, and the particular update was relating to active use of active leisure, but we note the point that was made by Councillor Condicore, and we will be picking that up through discussions with our Health and Wellbeing Partnership. Thank you.
Okay, just before I invite you to come in, I'd just like to make a general point. There's absolutely no doubt, with 2/3 of the adult population being obese or overweight, that it is absolutely essential for everyone as we age to move more, eat less, and therefore corporately we are very supportive of any actions which help people become more physically mobile. So if you need me to write anything to anyone, I'm very happy to put my name to any action which helps our citizenship become more mobile. Keith, they were the two answers to your questions. Is there any other points you wanted to make?
Thank you. Yeah, I know the hospital is very supportive of these things, but I'm really keen to actually get some pushback when we get this spin from where we've got this cycling thing in the park. But a lot of the more right wing now expect you to take the cycles to the park in their 4x4s and watch the children go around, whereas we really need this cultural change, which I think the NHS is very good at campaigning for, and particularly the big employer and the site you have at George Eliot could potentially be on the Nuneaton to Bedworth to Coventry cycle route, but that's been cancelled. Everything is being pushed back by this, or we need to be safe, we need to be in our boxes. Yeah, I was most annoyed by this Place North report, not actually saying, well, we've got a challenge with the infrastructure of our town, because we have got a very large anti-cycling lobby at the moment who are very aggressive at actually ruining all the projects in the pipeline. Yeah, we've got funding for cycle lanes and they're just not happening. So I just wanted to raise, I know it's not your fault, but I know you're also a great place to start championing the health benefits and effectively having less customers at your place because people are actually losing a few pounds and improving their mental health.
Yeah, no, if there's any sort of soft power we can apply, Keith, to help any actions in communities to help people move more and eat less, we will be very supportive. Please just indicate to us, but clearly there are areas, well, there's many areas which we're not responsible for. Sarah, with that,
solar panels, I just want to make sure when you put one of your buildings in, you have actually got the hooks there, so actually you can put solar panels on the roof when you get the funding, because it's so annoying to actually build new buildings and then not be able to retrofit solar.
No, that's a very good challenge, Keith. And Robin and Jenny, can we make sure we take that away so we don't score an unnecessary own goal? Any other questions for members of the public? Please raise a digital hand. David?
Thank you, Russell. It's not a question, Chair. It's a huge thank you to the members of staff from the George Eliot that braved the wet weather and took part in the Remembrance Sunday Parade at Nuneaton. And I look forward to perhaps better weather next year and probably a larger turnout from the George Eliot. But thank you for those that made the effort on that Sunday. Thank you.
No, thank you. Well said, David. And if there are no other questions from members of the public, I'd just like to close the meeting with wishing everyone the happiest of Christmases. Remember those members of our local communities who will be on their own, maybe for the first time having lost a loved one, are kindly knocking on a door to check someone's okay around Christmas can make all the world of difference to those who are lonely or in despair. So remember those who are less fortunate than ourselves at this time. Thank you to all of our frontline teams for the work they'll be doing. Those who won't be on holiday on Christmas Day because they'll be in the ED department or on wards, enormous thanks from everyone that we serve. In the meantime, I look forward to seeing you in the new year. Take care, everyone. And for my board colleagues, we will have a 10-minute break and then we'll get on with the confidential board. Thank you all very much. Take care.